Today, we're going to talk about the concept of perfusion and specifically talk about shock. Shock is a life-threatening condition that results from inadequate tissue perfusion. The tissues are hypoperfused, which prevents oxygen delivery to the cells. If we don't have oxygen to our cells, this could lead to cellular death, tissue death, organ death, or whole person death. As nurses, we have to recognize shock and understand that the underlying cause of shock needs to be treated. As early recognition and interventions will prompt improved patient outcomes. There are many types of shock, but of all the types, they all lead to cell dysfunction or death. So we can define shock as a clinical syndrome that results from inadequate tissue perfusion, creating an imbalance between the delivery of and requirement for oxygen and nutrients that support cellular function. Any of our patients that we take care of are at risk for shock. So any disease process puts a patient at risk for shock. So when we talk about shock, we have to know the background and what our body does normally. So to maintain adequate blood flow to our tissues and cells, our body has to have an adequate cardiac pump because we got to move that fluid. We have to have effective vasculature or circulation, so our vascular tone must be intact. And we also must have adequate blood volume or blood flow. So we must have our tank full. With shock, without proper treatment, inadequate blood flow to the cells or perfusion results in poor delivery of oxygen and nutrients, causing cellular hypoxia and then cellular death. If multiple cells die, it can progress to organ dysfunction or organ death. And organ dysfunction or organ death can present to whole body patient death. So adequate cardiac pump, we can think of cardiac output. So we must have a good cardiac output. The effective vasculature or circulation, we can think of as SVR, so systemic vascular resistance, and PVR, pulmonary vascular resistance. The adequate blood flow or volume, we can think of as preload or CVP. Shock is our body's response to any situation that causes poor oxygenation of tissues and organs. The tissue perfusion is not adequate to deliver oxygen and nutrients, so it's an imbalance between oxygen supply and demand. So oxygen demand is high, the supply is low. Shock is a life-threatening syndrome that can lead to MODS, which is multiple organ dysfunction syndrome. Shock affects all body systems, as you will see shortly. Shock may develop rapidly or slowly. It's depending on the underlying cause. Any client with any disease we said is at risk for shock. So you always want to keep it in the back of your mind. There are different types of shock. Underlying the causes of shock are going to be different, but ultimately the body responds almost the same way with multiple types of shock. We'll talk about what happens in the body first, and then we'll go into the specific types of shock. But as an example, you have hypovolemic shock. It results from hypovolemia, so we don't have enough volume. Cardiogenic shock sounds just like it is caused by something cardiac. So impairment or failure of our myocardium, so we don't have an effective cardiac pump. Septic shock, which is a type of circulatory or distributive shock that results from overwhelming infection. Neurogenic shock, it results from a loss of sympathetic tone, So it causes a relative hypovolemia. And then anaphylactic shock, which you guys talked about last semester, we're not going to talk about this time, but it is a type of shock. But it's a circulatory or distributive shock that results from a severe allergic reaction. So the primary underlying pathophysiological process and underlying disorder are used to classify the different types of shock. A lot of the treatment is the same in the different types of shock, but understanding the underlying cause will help you recognize it sooner. The pathophysiology behind shock. So our cells need ATP for energy. Energy for any process we do, even breathing, we need energy for. Usually, it's an aerobic process. So aerobic means with oxygen. With ATP, we use it for energy. Remember, we talked about even breathing, so muscle contractions, conductions of impulses. Think about the heart. So normally ATP is synthesized aerobically, so with oxygen. We can also synthesize ATP anaerobically, so without oxygen. However, our body likes oxygen because we can produce more ATP. But our body's smart enough that if we don't have oxygen or low supply of oxygen, we're going to synthesize ATP anaerobically so we can have energy. There is one caveat. If we do produce ATP anaerobically, we get lactic acid buildup. That lactic acid is an acid which can cause metabolic acidosis. So think about our marathon runners. They're running so many miles. They're not eating or drinking typically during these runs. They're depleting their energy stores faster than they can replace. So the body synthesizes ATP for energy using anaerobic metabolism. Have you ever heard of marathon runners having muscle cramps maybe during or after a race? This is why, because they have that lactic acid buildup from the anaerobic metabolism. Other things that happen in shock, our cells become more permeable and they swell. When they swell, this allows for fluid and electrolytes to seep out and into the cell, so balance is imbalanced. Sodium and water rush into the cell, cause it to swell. Potassium is then pushed out of the cell and into the bloodstream. So depending on the stage of shock, you will see hyperkalemia. Could be mild or severe hyperkalemia. Also, inflammatory mediators are released, so the stress response, cortisol, catecholamines, glucagons are all inflammatory mediators. They cause hyperglycemia and insulin resistance. Remember, if we don't have insulin or we can't use insulin, we can't get glucose into our cells. So with this insulin resistance, the glucose can't get into the cells, so then our cells are basically starved. So then the liver will start producing glucose from fats and proteins. It's good, however, we're breaking down muscle mass, and when we metabolize fats, we get ketones as a byproduct. Remember that diet, the ketogenic diet? That's essentially what you're doing, is you're breaking down your fat stores and you're getting in ketosis because ketones are a byproduct of the fat metabolism. Also, with this stress response, the clotting cascade is activated and it's overstimulated. So what this means is that the body will start producing microemboli into the microvascular, so the end organs. So you'll have little teeny tiny clots, multiples. This will cause all those clotting factors to be used up because we're producing multiple microemboli. So then if we're using up our clotting factors, then we start bleeding. So you're going to see clotting and bleeding at the same time. So here's a picture of that cell swelling. So see sodium rushing in. What follows sodium? Water. So sodium and water are rushing into the cell, causing that cell to swell. There's not enough room, so it kicks potassium out. So you'll see more potassium extracellularly, so in your serum. When we talk about tissue perfusion, we need to think about our mean arterial pressure, or MAP. The MAP is used to evaluate perfusion of organs. MAP is essentially your cardiac output times your peripheral resistance. So the MAP must exceed 65 millimeters of mercury for cells to receive oxygen and nutrients that they need to sustain life. You can think of MAP as our average pressure at which blood vessels move, or blood moves through the vessels. When we talk about peripheral resistance is determined by the diameter of our vessels, so whether our vessels are constricted or dilated. So normally, if we have a low MAP, our body senses the stress response, and the vessels either dilate or vasoconstrict to meet the needs. So if our MAP is low, our vessels are going to vasoconstrict to help increase MAP and blood pressure and perfusion to organs. So when we talk about baroreceptors, they're also called pressure receptors, but they're located in the carotid sinus and our aortic arch in our body. When blood pressure is decreased, there's a decrease in blood volume to these areas, and they sense that. They are responsible for regulating the circulating volume and also regulating other hormonal activities that help increase or decrease our blood pressure. So for example, when a drop in blood pressure is sensed, so the flow to these areas has decreased, epinephrine and norepinephrine are released from our adrenal medulla. Remember, epi and norepi are our fight or flight response chemicals. This results in an increase in our heart rate, and vasoconstriction happens, and these increase our blood pressure and cardiac output. The chemoreceptors, they're also located in the aortic arch and carotid sinus, but they regulate blood pressure and respiratory rate with changes in CO2. Also, the kidneys aid in blood pressure by releasing renin. So remember when you talked about the RAS system? So renin causes angiotensin converting enzyme 1 to be released, which is then converted to angiotensin 2. Remember, angiotensin is a potent vasoconstrictor. This also causes the adrenals to release aldosterone. And remember, aldosterone is our sodium saver. And what follows sodium? Water. With this sodium saver hormone, we get a relative hypernatremia, and it signals our pituitary gland to release ADH, so antidiuretic hormone, and this causes further water retention. So we retain the water instead of putting out the water through our kidneys. When we talk about shock, there are specific stages, and within the stages, we have degrees of compensation. So initial stage, you won't see many symptoms. It's hard to recognize. If we don't do anything in the initial stage, we'll convert into the compensatory stage, which is also called stage 1. It'll progress to the progressive stage, or stage 2. Then ultimately, if we don't intervene, it could progress to the irreversible stage, or stage 3, also called refractory stage. Another way we can classify shock, we can classify it as early or late stages of shock. But ultimately, as shock progresses through these stages, survival is less likely, especially by the time we get to that irreversible or refractory stage 3. For increased survival from shock, evidence says that as long as shock is identified, an aggressive treatment begins within 3 hours of identification, improved mortality can occur. So that means we have to recognize shock and intervene within 3 hours. So short time frame. With the initial stage of shock, we can also call this our pre-shock stage. So you're going to get a drop in your MAP of less than 10 millimeters mercury. So a little bit of a drop. It's still within normal limits. You still have a good blood pressure. Blood pressure is above 90, probably even normal. You have effective compensation at this stage. Oxygenation is maintained. You have an increase in your sympathetic tone related to that compensation. So you get a mild vasoconstriction and a slight increase in heart rate. Now, this increase in heart rate is not enough to be abnormal. So it's still within normal limits. But for example, say if your heart rate normally runs about 70s, maybe you're in the 80s now. It is hard to detect at this stage. Also, I want you guys to view a table in your book. It's table 14-1, and it's roughly on page 299 in your med-surg book. This table is all the stages of shock. The next stage is the compensatory stage. So it's what it says it is. This is the stage where the most compensation takes place, where you start to actually see signs and symptoms. So in this stage, our MAP will drop 10 to 15 millimeters of mercury from baseline, but it's still within normal limits. Blood pressure is still within normal limits. This is one reason why we trend our vital signs to see a decline in our blood pressure or a decline in our MAP. You will also see the pulse pressure narrow. So remember when we talked about increased ICP, you had a widening pulse pressure. Well, here your pulse pressure is narrowing. So your systolic blood pressure is lowering and your diastolic is either remaining the same or increasing. Compensation will take place. Our client will start to show numerous signs indicating that they have inadequate organ perfusion. So blood is being shunted away from the non-vital organs in this stage. Non-vital organs such as your skin, your GI tract, and your kidneys. And this allows blood to be shunted to the vital organs. So your brain, your heart, your lungs. We can't live without a brain. We can't live without a heart or lungs. You could live without kidneys, be on dialysis. Also, our sympathetic nervous system is stimulated. The kidneys will release renin. So remember, renin is going to hold our water. So you're going to see a decrease in urine output. You may also see some vasoconstriction to help increase that blood pressure. Patients may feel thirsty at this stage. They're just trying to get more volume, so the body makes them thirsty so that they will drink. At this stage, you'll start to see some of that anaerobic metabolism. And remember, the byproduct of that is lactic acid. So you might see a mild metabolic acidosis. Since we are in a metabolic acidosis, our respiratory rate will increase. This will allow us to blow off CO2 and increase O2. So if we're blowing off CO2 because we're tachypnic, that's going to decrease our blood levels of CO2. Remember, CO2 is an acid, so hopefully help compensate for that metabolic acidosis. In turn, you may even see a compensatory respiratory alkalosis in this stage. Your client may feel anxious or confused. It could be related to the hypoxia. It could also be related to that decrease in the CO2 levels. Remember, the hypocarbia causes vessels to constrict in the brain. Think back to ICP. Also, since the sympathetic nervous system is stimulated, remember, sympathetic nervous system speeds up. Our heart rate in this stage will be above 100, so not within normal limits anymore, be elevated. Our skin will appear cold and clammy, just related to that blood shunting away from those non-vital organs. Prognosis is usually better at this stage. So if we can recognize it in the compensatory stage and intervene, hopefully we won't have any end organ damage. So in this stage, treatment includes correcting the underlying cause. So if it's volume, we need to give them volume. If it's infection, fix the infection. We want to treat it in this stage so that shock doesn't progress into any of the later stages. So let's give them some IV fluids, some oxygen, medications. So if it is an infection, maybe antibiotics. Also, we need to draw some labs, your basic labs like a CBC, a chemistry. If we are worried about infection, draw some cultures, blood cultures, urine cultures, sputum cultures, wound cultures, all the above. The next stage is the progressive stage. So in this stage, we have a life-threatening drop in our MAP. So it drops more than 20 millimeters of mercury more. So we were about 10 to 15, now we're 20 more, so a total of 35-ish. So you can say that our systolic blood pressure is less than 90 or 40 millimeters from baseline drop. So my blood pressure was 120 normally, now I'm 80. Or if I have a lower end blood pressure normally, like 100, now I'm 60 systolic. So those mechanisms that regulate our blood pressure are no longer effective and cannot compensate. So remember, we're going to have an even more narrowed pulse pressure. So remember how to calculate pulse pressure, your systolic blood pressure minus your diastolic. We have even more shunting of blood. Skin will be mottled. You might even see some petechiae, and that's related to those clotting factors being used up. The heart is overworked. It begins to fail as a pump. So our heart rate in this stage will be greater than 150. So the heart's trying to compensate by increasing its heart rate, but really it's too high and our heart can't adequately fill. So this provides little perfusion and oxygenation to our organs. You can also possibly see in this stage dysrhythmias or MI related to this decrease in cardiac output. So if we drew cardiac isoenzymes like a CKMB and troponin, they might be increased. We also have increased capillary permeability, which causes fluid to leak out of our vasculature and into the tissues, causing a third spacing or edema. Remember, if it's in the tissues, our body can't use it because it's in the wrong space, so this further worsens blood flow to the heart. So it decreases our preload. If we have a decrease in preload, we're not getting enough blood flow out, i.e. cardiac output, so we're not getting enough perfusion to the body. Also, blood flow to the brain becomes impaired, so now you're really going to see those changes in LOC. Your patient may go all the way down the spectrum of unresponsiveness. With the lungs, respirations are rapid and shallow. We may need mechanical ventilation at this point. You may hear crackles when we auscultate the lungs. Their PaO2 levels are going to be decreased, so less than 80. So hypoxemia will be present. Their CO2 levels will increase, so greater than 45. The pulmonary vasculature is constricted, causing decreased perfusion to the lungs. Also, surfactant is not being produced. And remember, surfactant is the substance that's on the outside of those alveoli that allows them to expand and contract. If we don't have that, the alveoli will collapse. If those alveoli are collapsed, then gas exchange will be impaired. Also, since the capillaries are very leaky, so that capillary permeability has increased, you're going to get fluid leaking into the interstitial space in the lungs. This is going to cause pulmonary edema, and that's why you hear those crackles. It's going to further worsen gas exchange and even more alveolar collapse. This whole process is called acute lung injury. If acute lung injury continues and we don't intervene, it can cause those lungs to become very stenosed or very hard and fibrosed, and that'll cause ARDS, which is acute respiratory distress syndrome. And you'll talk more about that in Unit 3. With the kidneys, your urine output is going to be less than 0.5 milliliters per kilogram per hour. So for example, if I had a 100-kilogram patient, I would need at least, or I would see less than 50 milliliters per hour. But a good rule of thumb when we're talking about urine output is 30 mLs per hour. It's a good average. If you're less than 30 mLs per hour, you want to be concerned that the kidneys aren't being perfused. Maybe your patient doesn't have enough volume. So with the urine output being less than 0.5 milliliters per kilogram per hour, we can consider that as oliguria. So they're still producing urine, just not enough. It can also cause acute renal failure, or as it's called now, acute kidney injury. Well, we are going to be in full-blown metabolic acidosis now. So treatment at this stage will aid in recovery, but your patient still may have end organ damage. So the GI effects, so remember that blood is being shunted from the gut and up to the heart and lungs and brain. So GI ischemia can cause stress ulcers. These ulcers can also put the patient at risk for a GI bleed. With the GI ischemia, these patients also can experience a bacterial toxin translocation. So remember, in our gut, we have a lot of bugs, good bacteria, bad bacteria, but it's a nice fine balance. Well, if we don't have good blood flow to our gut, these bacteria can translocate, where they enter into the bloodstream through the lymphatic system and can cause infection. Remember when we talked about the clotting cascade? So here those microemboli are being deposited into the vasculature, so small emboli everywhere, a lot. This causes our clotting factors to become depleted. So if we don't have clotting factors, well, now we're at risk for bleeding. So we're clotting on one side, bleeding on the other. This is called DIC, disseminated intravascular coagulation. So with this syndrome, our coags will be elevated, so our bleeding times will be prolonged. You may see ecchymosis on your patient, so bruising, and petechiae because of the bleeding, the lack of platelets. With this stage, we need to support the patient and the family and provide clear, honest, consistent, open communication. We want to allow the family to visit. We also want to communicate with the family. Any updates, be honest. If the patient's not doing well, don't sugarcoat it. We also can encourage the family to help care for the client. A lot of times the family just wants to help, so if you give them a role, then they feel like they're helping, they can cope with things better. So maybe we can get them to bathe the patient or help us bathe the patient, feeding, oral care, anything like that. And then we also want to allow for shared decision making. So involve the family, involve the patient if they're able. When we're deciding on care, have them at the table. Have them allow them to voice their concerns or make decisions. So in the progressive stage, with that shunning of blood, all those non-vital organs have anoxia. So we're not talking about hypoxia, we're talking about anoxia, so without oxygen. Those vital organs are going to be hypoxic. So now the heart, brain, and lungs, they're going to be hypoxic. So we have no oxygen, so anaerobic metabolism again causes that metabolic acidosis. You're going to see a moderate hyperkalemia. So that potassium is going to be above 5. You're going to have tissue ischemia. We need to find the cause, correct it with fluids and meds. So during this stage, we need to support those body systems affected. So for example, if it's the lungs and they're failing and can't gas exchange, maybe we need to put them on the ventilator. If it's the heart not pumping, maybe we need to provide some sort of inotrope to increase contractility. Our organs and tissues aren't being perfused, so we need to give fluids, so optimize intravascular volume. We also need to improve the competence of that vascular system. Maybe our vessels are dilated and floppy because we have no sympathetic tone. Well, let's give them a medication to constrict those vessels. So a vasopressor or vasoconstrictor. Also during this stage, we need to provide nutritional support. So it could be enteral or parenteral. We need to monitor their blood sugars and control them. So ideally, we want their sugars less than 180. It used to be recommended a more tighter blood sugar, like 140 to 180, but it was really hard to maintain that, and there was a lot more hypoglycemia. So now they just say less than 180. So you could do that either by an insulin drip or subcut insulin. So we're going to be checking their blood sugars. If we're doing subcut insulin, we might do blood sugars Q4 or Q6. If they're on an insulin drip, we have to do blood sugars every hour. With that GI tract becoming ischemic and risk for stress ulcers, we need to do ulcer prevention. So you might see them prescribed a PPI, so a proton pump inhibitor, or an H2 blocker like Pepcid. We're going to continuously monitor their ECG, watch for dysrhythmias. We might do frequent ABGs, so we might put in an A-line. Probably going to do frequent chemistries, monitor their renal status, so their BUN and creatinine, as well as their potassium. These patients are going to need frequent assessments and vital signs. Assessments might be every 1 hour at first, to 2 hours to 4 hours. Vital signs might be every 5 to 15 minutes. If it is the lungs, we said we might need to do mechanical ventilation, so put a breathing tube down, hook them up to the ventilator. If they're not that far yet, we might do turn, cough, deep breathe and incentive spirometry. If their kidneys are affected and they need those toxins cleared, we might do temporary dialysis. Ultimately, we want to promote rest, so block your activities to promote rest. If these patients have a fever, so if their shock is caused from bacteria and they have a fever, we need to treat the fever and prevent shivering, because remember, shivering can cause increased metabolic demand, that can further worsen our shock because these patients don't have the oxygen to give. And then again, just encourage the family support and educate the family on treatment regimens. The last stage is our irreversible stage. So irreversible, not reversible. We have now progressed to the final stage of shock. You see my picture of the Grim Reaper? Usually in this stage, organ damage is so severe, the client doesn't respond to any treatments and cannot survive. Our blood pressure remains low despite treatment. And when we're talking about blood pressure and shock and low, we're talking about a systolic less than 90. The tissues become necrotic due to a lack of perfusion. When those tissues become necrotic, it worsens our lactic acidosis and our metabolic acidosis. In this stage, we get the MODS, so that multiple organ dysfunction occurs. The respiratory system can no longer oxygenate or exchange gas. Even if we put a breathing tube down, it still can't. The treatment in this stage is the same as the progressive stage until the client doesn't respond any longer. So we still may give fluids, still may do vasopressors, but the client will not respond. And ultimately, in this stage, it's hard to come back from. More than likely, you're going to see death. So we need to discuss this with the family and whether we need to stop all interventions. The family may be very confused as they see us working hard with all these interventions, but then we're saying that the client won't survive. It's almost like, why are we doing these interventions? So we need to be honest and clear. Probably going to have some family conferences just so we can all get on the same page and have that open dialogue. We may need to consult palliative care and or spiritual care. Allow them to be present at the table. Allow the family to see, to touch, and talk to the patient. Remember, hearing is the last thing to go, so allow them to talk to the patient. Even though the patient doesn't respond, they still may be able to hear the family. Then also, hopefully, we've addressed this in the previous stages, but if we haven't, we need to discuss any advanced directives like a living will, or if the patient expressed their concerns as to what they want or not done. So with the multiple organ dysfunction syndrome, it's basically altered organ function that requires a medical intervention for support. So for example, the lungs are failing, so we need to put a breathing tube and hook them up to a ventilator and initiate mechanical ventilation for gas exchange. So if we have dysfunction of one organ, there's a 20% mortality. So 1 in 5 patients will die with just one organ dysfuncted. If we have dysfunction of 4 organs, it's a 65% mortality. So for example, say we have a patient in septic shock who can't maintain their blood pressure. They can't maintain oxygenation, so the heart is affected, the lungs are affected. They probably are in some sort of acute kidney injury, so the kidneys are affected. And now they have absent bowel sounds. So they have a 65% mortality. So it's important to discuss with the family the likelihood for survival. And really, with all these stages of shock, it really depends on the client's ability to compensate and whether they had reserves at the beginning of the stages of shock or not. For example, if someone who drinks 3 liters of water a day and they have a GI bug where they're having a lot of diarrhea and vomiting, they may be able to tolerate that GI bug better than, say, a 75-year-old who just eats tea and toast all day, doesn't drink enough or eat enough. They may progress in the stages of shock faster than the other person who drinks the 3 liters a day. So now let's talk about the different types of shock. And when we talk about the different types, it's basically what is causing the shock, so the underlying cause. So the first one is hypovolemic shock. So basically, we don't have enough blood volume. So hypovolemia. It's our most common type of shock. But if we don't have enough circulating blood volume, this is decreasing our venous return. So then it decreases our preload, decreases our stroke volume, and decreases our cardiac output, which causes our blood pressure to drop. So with hypovolemic shock, it results from a loss of intravascular volume by 15 to 30%. So of our total blood volume, 15 to 30% is 750 to 1500 mLs. So not a lot of blood volume lost can cause hypovolemic shock. Can be caused from any kind of hemorrhage, maybe a fluid shift, severe dehydration, surgery, vomiting diarrhea, diuresis, diabetes insipidus, burns, peritonitis, or ascites. So remember when we talked about the status of the patient before they go into shock, this was important as far as their hydration status. So know your client's history. Do they come in and they're tachycardic and their blood pressure is low or maybe borderline low? Have they been up all night vomiting, having diarrhea from a stomach bug or food poisoning? We need to do some labs, maybe an ABG, hemoglobin hematocrit, especially if we're thinking it's bleeding. So think about a trauma. Maybe they're in a MVC, a motor vehicle crash, and they may have some internal bleeding. We might do a H&H, check their hemoglobin. We want to check their electrolytes, especially look at their potassium. So with hypovolemic shock, our goal is to restore volume and minimize or eliminate the cause. For example, if it's bleeding, let's stop the bleeding. If it's from diarrhea and vomiting, well, let's give them something to stop the diarrhea and stop the vomiting. When we're talking about the cause in bleeding, if it is overt or occult bleeding that we see, let's hold pressure. If it's internal bleeding, they might need surgery to stop the bleeding, so a surgical intervention. First, we want to give them oxygen and start 2 large bore IVs. If we can't get IV access, we can always start an IO, so intraosseous. We want 2 large bore IVs for a couple reasons. One, in case one goes bad, we still have IV access. And 2, we may be giving them lots of fluids or fluids and meds, and a lot of things aren't compatible, so we need 2 large bore IVs. Preferably 18s, so 18 gauges, but since they're hypovolemic, they may be clamped down, they might not have good veins. If all you can get in is a 20, we'll take it. So let's give them some crystalloids, number 1. So crystalloids such as normal saline or LR. So with the crystalloids, remember they stay in the vasculature. We're going to give them boluses of these things. The only 2 fluids you can bolus are normal saline and LR. If we know it's blood that they've lost, let's replace it with blood. We don't routinely give blood unless we know that's what they've lost. So blood is a colloid. Albumin is also a colloid that you might see given. So when we're replacing blood, so for every 3 mLs, or for every 1 milliliter lost, we're going to replace with 3 mLs. So 3 times as much than what was lost. If it's a massive hemorrhage and we're having to do massive transfusions, a lot of times they won't give just blood because their clotting factors may be wiped out also. So you may see them do like a 1-to-1-to-1 rule. So 1 plasma, 1 platelet, and 1 packed RBC. So every time you give a packed RBC, you're going to give platelets and plasma with it. Also, if we're doing blood, think about their hemoglobin levels. Remember, we want to optimize hemoglobin levels so that they can adequately transport oxygen to their cells and tissues. I had a patient who had a chronic GI bleed, and her hemoglobin was like 4 or 5. It's like half what it normally should be. So she actually had an MI and went into cardiogenic shock because her hemoglobin levels were so low. Also, if we're going to give blood, member type and cross. Now, we like to give cross-matched blood because reactions are less if we have cross-matched blood. However, if it is related to a trauma like an MVC, you might see them give trauma blood. Trauma blood is O negative, so they don't have time to wait on a type and cross-match, so they give O negative. Because remember, everybody can receive O negative. Also, if we're giving massive transfusions or IV fluids, we might need to warm them because otherwise it'll cause hypothermia. Also, monitor for fluid volume excess while we're giving all those fluids. After we give them fluids and or colloids, we can do some vasoconstrictors or vasopressors like norepinephrine. It's just going to vasoconstrict those vessels to increase our blood pressure. Also, position them in the modified Trendelenburg. So remember the passive leg raise. So just put their legs up. Don't put their head, leave their head down, but not any further. So not like a full Trendelenburg. So we don't like to do the full Trendelenburg because one, it can cause breathing difficulty because all that fluid, all those organs are now sitting on your lungs and you can't take a good deep breath. And we're worried about oxygenation. And if you can't take a good deep breath, then you can't get oxygen in. Also, we don't like full Trendelenburg because it tricks our baroreceptors. Remember those receptors in our aortic arch and carotid sinus? They're sensitive to pressure. So if we put our patient in a full Trendelenburg, they're going to think that they're getting all this blood flow and pressure is good. So they're not going to start those compensatory measures. So with hypovolemic shock, when we're talking about hemodynamic monitoring, you'll see a low CVP because they don't have volume right. So low preload, low CVP, low blood pressure, low MAP. Our SVR, systemic vascular resistance, also our afterload, will be increased. So our vessels are going to vasoconstrict. Remember that compensatory mechanism? So if our vessels are vasoconstricted, that's going to increase our SVR. So our stroke volume and cardiac output, remember they're opposite of our SVR, so they're going to be decreased. So with the SVR, those vessels are constricted, and then with stroke volume and cardiac output, that heart is going to have a hard time pushing out that volume with those vessels constricted. Also, cardiac output and stroke volume are low because our preload is low. We don't have enough volume, so it's kind of twofold. Our next class of shock is cardiogenic shock. So it occurs when the heart's ability to contract and to pump is impaired, and the supply of oxygen is inadequate for the heart and tissues. So basically, our heart fails as a pump, so that decreases our cardiac output. If we don't have good cardiac output, we don't get good oxygen or perfusion to the tissues. With cardiogenic shock, it can be caused by coronary and non-coronary causes. So example could be an MI. So maybe they had a big MI with the anterior wall affected from that LAD. So our left anterior descending vessel has affected that anterior wall of our left ventricle. And remember, your left ventricle pumps blood to your whole body. So if we had that LAD lesion, now our whole left ventricle has been infarcted. It's not going to work, can't pump to the whole body. It can put us in cardiogenic shock. Other causes could be cardiomyopathy, valvular disease or damage. So our valves aren't working right in our heart. Maybe cardiac tamponade, where that heart can't fill because it is surrounded by blood. Or even dysrhythmias like VFib. Other things that are non-coronary that can cause cardiogenic shock are acidosis, hypoxemia, and tension pneumothorax. So with the tension pneumothorax, one of your lungs has collapsed and the air can't escape, so it puts pressure on that side, and it can also displace the heart. And if it displaces the heart, then the heart can't fill because it's being squeezed or pushed to the side. If it can't fill, it can't pump, and that can cause cardiogenic shock. So treatment, we got to treat the underlying cause. So if it is from an MI, let's go to PCI or CABG or fibrinolytics. If it's from valves, let's do valve replacement. If it is from some sort of heart failure, let's do a ventricular assist device, so a VAD. If it's from a tension pneumo, let's put a chest tube in. If it's from a dysrhythmia, let's correct the dysrhythmia. But our goal is to limit further organ damage or preserve cardiac function. So we want to increase cardiac contractility while decreasing afterload. So the heart fails as a pump, so we need it to pump. So let's do stuff to increase contractility or pump. And remember, afterload, we want those vessels open so that the heart can squeeze that blood out. So let's decrease our afterload. So let's give some oxygen. We might need to do pain control, especially if it's from MI. Remember, the pain increases our oxygen demand. Also, pain, especially chest pain, can signify ischemia. Let's draw some labs, like a BNP, so a brain natriuretic peptide, BNP, looks at our heart failure. Some ISOs, so CKMB troponin. We may give some fluid boluses. However, if our heart's not pumping effectively, we have to be very careful with these fluid boluses. Watch for fluid volume excess, because fluid may be backing up if it can't go forward because the heart can't contract. We're going to monitor their rhythm, their cardiac rhythm, look for dysrhythmias or ST elevation or ST depression or T-wave inversion. You might do serial 12-lead EKGs, so we might do one every 4 hours or as needed. Here we need to increase contractility, so we may do some inotropes, so inotropic support like dobutamine and DIG. They increase that contractility of the heart. We may also give vasodilators. So these vasodilators are going to decrease preload and afterload. What is one drug you can think of that vasodilates to decrease preload and afterload? Nitroglycerin. So we might do a nitroglycerin drip. We want to decrease preload to limit the workload on the heart. And we want to decrease afterload to vasodilate so that the heart can squeeze that blood out effectively. You may also see antiarrhythmics. So if it's from a dysrhythmia, you might see them on amiodarone or lidocaine. We talked about the ventricular assist devices. They may also be put on the aortic balloon pump, which you'll talk more about in the cardiomyopathy lecture. And probably the last resort or most emergent treatment could be cardiopulmonary bypass. So we bypass those heart and lungs to get blood flow to the periphery. So with cardiogenic shock, in terms of hemodynamic monitoring, you'll see low cardiac output, low stroke volume. Our CVP may be increased, and that's just because that heart can't pump the blood out, so it's backing up in the heart. We'll have an increase in SVR, so increased systemic vascular resistance. So normally, compensatory mechanism, if we're not getting good blood pressure or cardiac output, those vessels are going to constrict to help with that. And if we're talking about a wedge pressure, a pulmonary capillary wedge pressure, it might be increased because, again, blood is backing up in the heart and not moving forward. Our last shock that we'll talk about is neurogenic shock. So this is the shock that's most different from all the rest. It's a circulatory or a distributive type of shock, but it's caused from a balance or an imbalance in the parasympathetic nervous system and sympathetic nervous system. So something happens, maybe it's a spinal cord injury, maybe it's from spinal anesthesia or other nervous system damage. So something happens, we get vasodilation because we've lost our sympathetic tone. So remember, the sympathetic nervous system speeds things up, so it vasoconstricts, increases our heart rate. So if we lost that, now we have the parasympathetic nervous system taking over. So we get overwhelming vasodilation, the heart rate decreases. So here we have the maldistribution of volume. So we have the volume, it's not that we've lost it, it's just our vessels are vasodilated and our heart rate's low, so all that volume is in our periphery. So we have decreased venous return. So it's not coming back to the heart. If it's not coming back to the heart, then our cardiac output is going to be decreased. If we don't have good cardiac output, then our tissue perfusion is going to be decreased. And this is what throws us into shock. So since we have this overwhelming vasodilation, we have pooling of blood in the periphery. So these patients, instead of looking cool and clammy, they're going to be dry, warm, and pink. Their pulses are going to be bounding. So here, instead of shunting blood, they're vasodilated, so their pulses will be bounding. Treatment or nursing care. If we do have a patient with a spinal anesthesia, make sure their head of bed is increased to at least 30 degrees so that that anesthesia doesn't go up, it goes down the spinal cord. If we are worried about a spinal cord injury, make sure we have cervical immobilization. So put the C-collar on, have them on the backboard until we rule out other damage. Since they have vasodilation, we may put them on vasoconstrictors. Also with the vasodilation, we need to do DVT prophylaxis because they have pooling of blood in that periphery. So in regards to hemodynamic monitoring, you're going to see a decrease in systolic vascular resistance because we're vasodilated, a decrease in cardiac output because blood is pooling and it can't get back up to the heart, a decrease in CVP, same reason, it's not getting back to the heart, and our wedge pressure may be decreased because of the vasodilation. So just to review, when we talk about all those compensatory mechanisms, so something happens. So in this instance, we stepped on a piece of glass, I'm bleeding. I have an acute bleed, so I'm losing volume. If I don't have volume, I don't have tissue perfusion. If I don't have tissue perfusion, our cells begin to metabolize anaerobically, so without O2, so that's when you get your lactic acid buildup. So then fluid moves into the tissues. Our chemoreceptors in the blood decrease that were acid or sense that we're acidotic. So they activate the respiratory centers. That's when I increase my respiratory rate. So I'm blowing off that acid to compensate. I'm also increasing my respiratory rate to get oxygen in to my cells. The baroreceptors sense the decrease in blood volume and blood pressure. So it activates the sympathetic nervous system, which causes vasoconstriction and increased heart rate. So you'll see tachycardia. Those pulses will be weak and thready because of the vasoconstriction. The skin will be cold and clammy, maybe even cyanotic, again from the vasoconstriction. So with that vasoconstriction, those kidneys and the lack of blood flow, the kidneys can sense that and they release renin. Renin causes angiotensin II to be produced. Remember, angiotensin II is a potent vasoconstrictor. This also causes the adrenals to release rennet or aldosterone, which is our sodium saver. What follows sodium? Water. It also stimulates the pituitary to release ADH. So remember, antidiuretic hormone, we're going to hold on to even more water. So this is going to decrease our urine output, hopefully increase our blood volume, hopefully increase our blood pressure. So if we can kind of sum up the medical management for all the types of shock, we want to support our affected systems. The first one being that respiratory system. So give them some oxygen. If they need it, put them on the ventilator. If they are on a mechanical ventilator, we want to prevent VAP, ventilator-associated pneumonia. And we do that by providing oral care. If we're going to suction them, it needs to be aseptic or sterile technique. We don't want to introduce pathogens because with that breathing tube, we just bypassed all their natural mechanisms, and those germs can go straight down that tube and into the lungs. So when we're suctioning them, make sure it's sterile technique. A lot of times these apparatuses the suction catheters will stay in a sleeve connected to the patient. Increase their head of bed to at least 30 degrees to help prevent aspiration. We're going to do a daily sedation vacation where we turn off or interrupt their sedation and we assess for their readiness to extubate. Because if the longer we leave them on the ventilator, the more risk they are for this ventilator-associated pneumonia. Fluid replacement. So isotonic fluids, crystalloids. Remember, isotonic, I stay where I put them. Could be normal saline or LR. Ringer's lactate has a lactate ion that buffers the acid, because remember, we're acidotic in shock. But with isotonic fluids, they have the same concentration of electrolytes as extracellular fluid. With the isotonic fluids, we may lose some to those tissues because of the leaky capillaries, so we might need to give them more than what we think they have lost. So watch for edema. Also, while we're giving fluids, watch for any fluid volume excess like crackles or edema or JVD. We got to find the right balance of fluid because too little will actually increase mortality because they don't have perfusion, but too much will cause fluid volume excess and increase mortality. We can also give them colloids, especially if we know that it's blood that they have lost. So it's not our first choice. We want to give crystalloids or isotonic fluids. We can give colloids like blood or albumin, but basically colloids are molecules that are too large to pass through the capillary membranes, so they expand the volume, increasing or maintaining oncotic pressure, so fluid shifts or stays in the vessels. So with colloids, they do have some disadvantages. They're expensive because they come from blood products. And actually, colloids have shown not to decrease mortality. So that's why we don't like to give them as first choice. Also, while we're replacing fluids, we need to monitor CVP, so central venous pressures, our fluid status. We can monitor CVPs with any central line or PA catheter. And remember, with the central line, the tip of that central line sits right above the right atrium in that SVC or superior vena cava. And with the PA catheter, the port for the CVP sits in the right atrium. The CVP measures fluid returning to the heart, i.e. the preload. Normal CVP is 2 to 8. However, with shock, we want their CVP 8 to 12. And that's just related to those leaky capillaries. We know fluid's going to leak into the tissues. So let's beef up their CVP, make it 8 or 12, because we know some of it's going to be lost. Also, don't use a CVP value alone. Take it in correlation with other things and other assessments for fluid status, like our urine output, our heart rate, and our blood pressure. For example, if we had a CVP of 3, well, that's normal CVP, maybe not normal for shock, but normal, but their blood pressure is less than 90, their heart rate's over 100, and their urine output is less than 30 mLs per hour. Well, just because they have a CVP that's within normal limits, but we're seeing other signs, let's give them more fluids, get their urine output, blood pressure better. Also, medical management is vasoactive medications. So make sure you look at that table 14-2. It's roughly on page 307 in your MedSurg book. But with vasoactive medications, they can increase contractility and cause vasoconstriction. Some of them just solely cause vasoconstriction and don't mess with the contractility. While we're giving these vasoactive meds, we need to monitor vital signs every 5 to 15 minutes. They might need an A-line placed for this reason. With these vasoactive medications, watch for extravasation and infiltration, because especially the vasoconstrictors. So if those medications get into the tissues, they're going to vasoconstrict those vessels, limiting blood flow to the tissues and may cause tissue necrosis or tissue death. I had a patient who had norepinephrine infusing through a right hand IV, like a peripheral IV, and it infiltrated so bad that it caused tissue necrosis of her hand, and she actually lost her hand because of it. So we do not prefer to infuse them through a peripheral IV. I mean, if that's all you got while you're waiting for a central line to be placed, then you can use it, but it's not preferred. A central line is preferred. If you're going to use a peripheral IV, like you're waiting on the doctor to come put a central line in, just make sure that it has blood return before you infuse that vasoactive or vasopressor medication. If you don't get blood return, don't use it for that medication. Maybe start a whole new IV. With the vasoactive medications, we as the nurses will titrate it based on our orders and protocol. So the physician may order norepinephrine, titrate to maintain a MAP greater than 65 or a systolic blood pressure greater than 90. And then it's our job to follow the specific protocols. So your hospital may have protocols already in place. You may need to look up on your med reference how to titrate specific medications. With any of these vasoactive meds, once they're no longer indicated, so say our blood pressure has stayed up, we probably need to get the vasopressor off. We must taper it down. So don't just turn it off. Oh, their blood pressure is good. I'm just going to turn off the norepinephrine. Don't do that. So don't abruptly stop it, because they will have a dip in their blood pressure and may not be able to come back from. So slowly taper it off. Just as you titrate it up, you want to titrate down. Also with our central lines, you want to prevent the CLABSI, so the central line associated bloodstream infections. So sterile technique during insertion. So you're sterile. If you're helping the doctor stays sterile. Hand hygiene and put on clean gloves before you flush or do anything with the central line. Scrub your hub with either an alcohol-based or chlorhexidine gluconate CHG-based cleaner before you access. And then we need to assess it daily for the need. Do we still need this central line? If we don't, then it needs to come out, because the longer it stays in, the more risk they are for infection. So make sure you look at chart 14-2 on page 306 again in your MedSurg book. Also, for all the shocks, we need to do nutritional support, because remember, their caloric needs are very high. So they may require up to 3,000 calories per day. You know, normally we require 1,500 to 2,000 calories a day. Well, they may require 3,000, almost double. If they don't have these calories, they'll break down muscle mass, which is not good because one, you need muscle, but two, it's going to prolong your healing. So let's give tube feedings. We can either do enteral tube feedings or parenteral like TPN. Enteral is preferred, so we might need to put a feeding tube down like an NG or a Dobhoff. We want to do enteral for a couple reasons. One, remember we talked about those capillaries being permeable and that bacteria translocation. If we start feeding the gut, that will help prevent that bacteria from translocating. Also, we don't prefer TPN because one, you have to infuse it through a central line, and two, it's very sugary and it can cause infection. While we are doing tube feedings through a feeding tube, we need to check our residuals at least every 4 hours and then hold them if those residuals are high. So basically, you're going to check how much is left in the stomach every 4 hours. If we're still having the same amount of tube feeding over 4 hours in that stomach or even more, that means it's not moving forward. So the gut's not working. So we may need to A, slow down the tube feedings, or B, hold the tube feedings for a period of time. And then assess placement every shift. Also, with the glycemic control, remember we want to check their blood sugars and keep it less than 180. Might do subcut insulin or insulin drips. We also want to assess for delirium. So delirium in the ICU is big. If our patient experiences delirium, their mortality is increased. So with delirium, we can use the Confusion Assessment Method Tool ICU, so the CAM ICU. If you look in your med-surg book on page 211, the chart 11.7 gives you all the information for that CAM ICU tool. And you may do this every 4 hours or every shift. It just depends. You may do it, as needed. If you did it once already your shift and you notice or you're starting to suspect signs of delirium, then go ahead and do another one. So another review, your stages or signs of shock. So those early signs, look at our patient. They look good, right? Their MAP has decreased 10 millimeters of mercury from baseline. So maybe not enough that you'll notice it unless you're really trending. But they have effective compensation, so adequate oxygenation, adequate perfusion. Their heart rate may be slightly elevated, but still within normal. Then we go to the compensatory stage. So now their MAP has fallen 10 to 15 millimeters mercury from baseline. Renin, ADH, vasoconstriction, decreased pulse pressure. Our heart rate's going to increase. We're going to be acidotic. Your patient may appear restless or apprehensive. So LOC changes. The progressive stage, so now our MAP has dropped 20 millimeters from baseline. You're going to see their systolic blood pressure less than 90. They have tissue and organ hypoxia. The oliguria, the urine output will be low. They'll have a weak and rapid pulse. Remember, their pulse is greater than 150. Even more acidosis. And they may be very lethargic, maybe even comatose. Then we get to the last stage, the refractory or irreversible stage, excessive cell and organ damage, MODS, the multi-organ dysfunction syndrome, acidosis, and death during this stage. So let's do some examples. So we have a 55-year-old male, post-op day 0, so just had surgery, status post-colectomy. The doctor was called because the patient is tachycardic, hypotensive, remember we're talking about systolic less than 90, altered mental status, abdominal distension, and a decreased urine output. The patient is pale, disoriented, their abdomen is very tense and rigid, and their urine output is 15 mLs per hour. What is your diagnosis? What do you think happened? What additional information should you obtain? What's the plan? So the patient just had surgery. What's a major risk of surgery? Bleeding. So let's see, they're tachycardic, hypotensive. So the reason they're tachycardic is because their blood pressure is low, their heart's trying to compensate. Altered mental status, well, because their blood pressure is low. Abdominal distension and rigidness. Ooh. And then a decreased urine output. So maybe they're hemorrhaging inside where they did surgery. Maybe they forgot to tie off a blood vessel. So maybe the patient needs to go back to surgery for an exploratory laparotomy. Open them up, see if there's any bleeding. If there is, fix it. What type of shock is this? So they're bleeding out, so they're losing volume. So it's hypovolemic shock. Good. What additional information should you obtain? So we know they're bleeding, so maybe we need to do some coags, so PT, INR, PTT, maybe anti-XA. We know they're bleeding, so we're probably going to replace them with blood. So let's type in cross and do a CBC to look at their hemoglobin. So what's our plan? Think about shock. Well, one, monitor your ABCs, airway, breathing, circulation. Those are priority. So we may need to intubate. Circulation, we're probably going to give blood and IV fluids, so they need a patent IV. If we're giving blood, it needs to be at least a 20 or greater. So IV fluids with isotonic IV fluids. And then we need to prepare them to go back to surgery. So, number 2, we have a 75-year-old male, history of CAD, coronary artery disease, PVD, peripheral vascular disease, diabetes mellitus. He is post-op day 1, so had surgery yesterday, status post AAA repair, abdominal aortic aneurysm repair. He's complaining of nausea. What do you need to think about? What's the plan? So he just had a AAA repair, but he also has other cardiovascular risk factors, diabetes, PVD, coronary artery disease. So he's complaining of nausea. What does that kind of sound like? Is that an atypical sign of something? Maybe ACS? So let's diagnose him. He had an MI. Remember ABCs, airway, breathing, circulation, MONA, but not in that order. Beta blockers help reduce that cardiac workload. Let's do some labs. So cardiac isoenzymes, every 8 hours times 3. Probably do a 12-lead EKG, a blood sugar check, a chemistry, and a chest x-ray. And of course, consult with cardiology. So they come, determine he's having an MI, so ACS. He's going to the cath lab. They found critical stenosis of the left main and fixed that left main occlusion with balloon angioplasty. So remember, your left main coronary artery supplies blood flow to the left side of your heart. So after cath lab, he was intubated. His blood pressure is now 80/50. His urine output is 10 mLs per hour. So remember, good urine output is at least 30 mLs per hour. We do an echo, so a TTE, a transthoracic echo. We see that he has severe left ventricle dysfunction. So remember that left main occlusion has caused that left ventricle to infarct. So now the left ventricle can't pump blood to the body. So automatically, what do you want to think about? His blood pressure's low, urine output's low, he's intubated, so he has respiratory failure, his lungs are failing. What kind of shock is this? That's right, cardiogenic shock. So what are we going to do? ABCs, airway, breathing, circulation. If he needs pressors, let's do vasopressors. If he needs inotropic support to squeeze and contractility of the heart, We can place a Swan-Ganz or PA catheter, measure all those hemodynamic values like CVP, cardiac output. He may need a balloon pump, an intra-aortic balloon pump, or some sort of cardiac assist device to help with that contractility. Because once that tissue, cardiac tissue has died or necrosed, it's not coming back. Good. All right, so now we have a 55-year-old, post-op day 0, status post-colectomy. He has an epidural placed for post-op pain control. So the physician's called by the nurse for hypotension and bradycardia. Bradycardia. Okay. He is alert and oriented ×3. His abdomen is non-distended, non-tender. Recent post-op labs, his hematocrit was 35. What do you think? So he's hypotensive and bradycardic, and he's getting an epidural. What kind of shock does this sound like? Remember, it's the type of shock that's different from the rest. Yep, you guessed it, neurogenic shock. And it's secondary to his epidural. So how do we treat it? We can give him some IV fluids. We can turn down or turn off the epidural. Remember, increase the head of bed to at least 30 degrees. If the blood pressure doesn't respond to those IV fluids, we can initiate vasopressors, such as phenylephrine, just to squeeze. Remember, with neurogenic shock, they have overwhelming vasodilation. So take-home tips with shock. Shock is basically inadequate tissue perfusion. There are different types of shock, like hypovolemic, septic, cardiogenic, neurogenic, and anaphylactic, but they all result in inadequate tissue perfusion. Major signs of shock are altered mental status, tachycardia, and hypotension, tachypnea, low urine output. Now remember, the tachycardia is a little bit different with neurogenic shock, but always start with your ABCs, airway, breathing, circulation. Make sure they have a patent IV. Make sure we give them oxygen, mechanical ventilation if needed, intubate them. Resuscitation begins with fluids. So fluid resuscitation, remember your isotonic fluids, normal saline or LR. If we know it's blood that they've lost, give them blood. We can give them vasoactive medication. So if we're going to do vasopressors, we need to fill their tank up first. So anytime you do vasopressors, make sure you do fluids first. Because if they don't have fluids and their tank's not full, and we give them a vasopressor, well, there's nothing to squeeze. So make sure you fill their tank up first and then do your vasopressors. If it's cardiogenic shock, we might give them vasodilators. And then nutritional support. Remember, nutrition's big. They need a lot of calories. All right, that concludes our lecture on shock. We will talk about septic shock in a different lecture, so be on the lookout for that.